Hi, everybody, and welcome to the Mind on Mental Health podcast. My name is Andy Dean, and I'm a licensed clinical social worker. Today, I'm once again speaking with Dr. Susan Murray, supervising psychologist at Penn Medicine Princeton Center for Eating Disorders. Today, Dr. Murray and I discuss common misconceptions about eating disorders and what effect GLP-1 use is having on this population. I hope you enjoy this episode and find it helpful. I wanted to ask you about misconceptions about the illness. I think that's important for just the general public, but like family members, patients, as well as other clinicians. We've been talking quite a bit about anorexia. Mm-hmm. So maybe we could just start there. Like, what are some of the common misconceptions you think that exist out there in regards to the illness?
So one, I think that's commonly thrown around colloquially is that it's a phase, right? Okay. That people will have a phase like this during their teenage years maybe, and then they'll fall out of it through time, right? And that can be the case for some people, but that's not usually how illnesses work. The more time that we are behaving and thinking in a certain way, right, we tend to get entrenched into patterns and habits. And so I think that I would not treat lightly someone who is starting to show signs like that, thinking that it's just going to be a phase, because I have many, many patients on our unit who are well into their 50s, 60s. We have a patient in her 70s right now, all of whom developed their illness in the teenage years, or many of whom developed their illness in the teenage years. And so I would hope that we would think about that as like, we need early intervention and not like, oh, that'll resolve with time, because that is not a guarantee.
So like, what would you say to a parent who has a teenager where they think they're going through one of these phases? Like, what are the things they might notice, and what might you recommend that they do differently?
Right. So if their child is cutting back on certain foods, avoiding certain meals or snacks, if they notice they're exercising a lot more, they're going to the bathroom right after meals and snacks, right? Those are times to have a conversation early, and to talk about perhaps getting treatment. That could maybe be started at an outpatient level and see if that helps to resolve the problem. But I would have a conversation very early about what's going on, that you're concerned. No one really should be losing weight during development. There are some circumstances maybe that a doctor would, I don't know, I'm not a medical doctor, but just generally speaking, you're supposed to be developing your body and growing. And so if someone has even stopped growing, right, maybe they are not losing weight, but they've stopped on their developmental trajectory, that's a time to really touch base and see what's going on.
Okay, that's a good point. But also, it sounds like the thing you would say is like the earliest that you can catch this and the earliest you can address it, the better.
Yeah.
Okay.
Right.
What other misconceptions are out there in regards to that illness or anorexia?
I think there's a lot of misconceptions around it being like a female-only illness. And it is true that it is more prevalent in women, but I treat males all the time who struggle with anorexia. And so I think it's very difficult for them to seek treatment because they don't think of themselves as someone who might struggle with anorexia.
Interesting.
And it can be difficult to go to treatment, right, when you are feeling like this is a female condition, right?
Right, good point.
It's also harder for family members, medical providers to really detect, because they're not necessarily applying that lens, right, to men or boys. But it can be just as severe in men and boys. So really, like, broadening our lens to think that anyone can suffer with this illness.
I'm curious about what might be different for men and boys.
Yeah.
Like, I guess, how might it present differently? And maybe it doesn't at all. But like, what might they like go into a doctor's office complaining about, or like, what might parents notice that might be different from girls? Like,
I think there's usually a focus a little bit more on like muscle toning, things like that women might not be reporting or as be as preoccupied. Like the outcomes that they're wanting for their bodies might be a little bit different, but the process of the illness is going to be very similar around tracking and modifying macronutrient intake or calorie intake. And I think, unfortunately, a lot of us have ideas around men engaging in these behaviors as being like health focused, and they're sort of normalized, and sometimes they are very, very disordered and unhealthy.
Yes.
And they don't think about those in those terms, but ultimately with anorexia, you're going to see fear of weight gain, weight loss through time, overexercise, things like that. So there are some commonalities, but what someone might be speaking about might be more like, I want to look, more toned or muscular, or I want to be more fit, whereas that may or may not be something that a woman says.
Yeah, okay. That answer, for some reason, made me think a lot about psychological flexibility and like the inflexibility that might be present if you ask them to not go to the gym or to eat something, a pizza, even though that's more carbs than it is protein or something.
Yeah. And then you start to see, like, once you're encountering rigidity, you know you're kind of onto something.
Yes. Yeah. Okay. Other anorexia misconceptions.
Another one is just that someone has to be, emaciated or frail in order to be struggling with this illness. There's a lot of individuals who meet for what we now call atypical anorexia. They're not necessarily underweight, right? But they are preoccupied with their weight, with caloric intake. They are engaging in all kinds of disordered behaviors and would meet criteria for an eating disorder, but sometimes are not being identified because they, including in themselves, right? Because they are not presenting in this like one way.
I guess I'm just thinking about myself, and I could totally picture myself as a clinician missing that.
Yeah.
Right. Like that's one of the clear things that you look for. And again, this is my ignorance, but like it's more about the behaviors you're saying than it is about
and the cognitions
than it is about the body size necessarily.
Yeah.
So I just think from an assessment or evaluation standpoint, whether it's like a PCP, like a medical doctor, or even other clinicians that aren't trained to look at this, that could easily be missed.
Yeah.
I don't want to go back to the well too much on this because Becca and I just spent a decent amount of time talking about it, but I'm curious about the media and GLP-1s, and I was talking to her a little bit about looks maxing for the boys, and how that might intersect with what the, I guess, conventional wisdom or like the wisdom that might be out there in terms of eating disorders. You have a lot of expertise when it comes to the neurobiology of eating disorders. And I am really curious about how that intersects or what the research says when it comes to GLP-1s, just because they're so prevalent now.
Right.
So I'd just be really curious to hear your perspective on what those medications are doing.
Yeah. So I think one thing that people don't have an awareness of or appreciation of is that when you affect one system in the brain, right, there's a complex set of interactions that can take place with different systems or pathways in the brain, right? So people don't really have a lot of awareness around the fact that when you act on GLP-1 receptors, you're actually going to be downstream affecting things like dopamine or reward pathways. And so now we're hearing a little bit more anecdotal reports of folks who are taking GLP-1s who are then reporting that they have a lack of motivation, kind of a blunted affect, not as excited to be doing things in their life, which makes sense to me because I understand how these things are connected a little bit.
That also sounds familiar. That sounds like the thing we were talking about earlier about if you take someone who's malnourished on a deserted island and bring them back here, they'll report some of the stuff like that.
Exactly. So I think some people think, I'm going to go on a GLP-1, I'm going to lose weight, I'm going to feel happy, and they're like, wait a minute, I don't want to do the things that I used to want to do. And so I think it's really important for potential patients and providers to be aware of this interaction so that we don't just jump to maybe diagnosing depression without understanding that someone's on a GLP-1. And that someone can understand if, how this is going to impact me. And it's going to be very individual. Some people will not have that journey, right? But we don't have a lot of personalized medicine right now around neurobiology to say you're going to have this kind of path.
That reminded me of oftentimes in therapy, it'll come up, people will ask do you think I should go on an antidepressant? Or they'll be weighing out the pros and cons. And I would say, hey, I'm not a doctor, but it affects everyone differently, essentially.
Right.
And the side effects are different for everyone because I think largely of what you're saying, that once you start affecting neurobiology, I think of it as like a shotgun approach where if you bring one neurotransmitter up, well then you don't know what's going to happen.
Exactly.
What the downstream effects of that will be.
Exactly. And that's not to say that medications and this type of medication can't be very helpful for some people, right? So modulating the reward system could be actually quite helpful for someone who's struggling with addiction that's mediated by dopamine. And so I think it's just that everyone has a different brain and a different kind of psychological context, right? And so we want to be having richer conversations around these things. Right. Another thing I will just say, because I can't help myself, is that it really bothers me the way that GLP-1s are often prescribed online. So for some of my patients, they've been struggling with eating disorders their whole life. They're really underweight. They have an illness that is really maybe bringing them to seek a GLP-1, and it's not being adequately assessed. This patient is not being adequately assessed. They're being prescribed GLP-1s when they're not in a state that they really meet criteria.
Reminds me of that when we were just talking about the anorexia, how it's not necessary. It's not always necessarily associated with a lower weight.
Right.
So you can have people with anorexia being prescribed GLP-1s.
Exactly, but even folks who are quite low weight are going online and getting prescribed GLP-1s, and it's very dangerous.
Yeah.
So, yeah, that's something that I think is just really important that we have safer practices around, more regulation around and screening for eating disorders. I also think there's a real chance that some folks with GLP-1s, again, are not going to know that they have a genetic vulnerability to develop an eating disorder. And they are going to begin to come into the malnourished state as a result of being on these medications that might really cascade into an eating disorder. So there's a lot of risk here that I think is not being
adequately assessed for either.
Yeah.
Okay. I guess something I'm curious about in regards to these medications are, I'm assuming the answer is yes, but can they be abused, and how do you find that happens in an eating disorder? Does that happen in an eating disorder treatment context?
Certainly, yeah.
How? How are they abused?
Yeah,
by being prescribed them in general?
Exactly, for folks taking medications that are going to curb their appetite when they are really already, not eating very much, right? Where they're malnourished. They certainly don't need something else to kind of quiet the part of their brain that is actually trying to help them survive.
Yeah.
That was the reason that one of the patients had cited. She was prescribed a GLP-1 after, she was very ill. And she was prescribed a GLP-1 to treat the food noise that she had. And the food noise was her brain saying I'm hungry. I need this to survive. So we don't want to quiet that. That's like putting tape on your gas tank indicator, right? We need to get that signal. And also
we need to, when Becca was here, I made this analogy between this and sort of using a benzodiazepine when you're feeling anxious.
Right.
Because the other piece that then you're not giving the patient is the opportunity to learn how to manage that when it presents itself.
Right, yeah. So I think, I'm not anti-GLP-1,
right.
I think there's different indications for different people, but we are going to see probably a lot of downstream effects in the eating disorder world as a result of it, so I think it's important to be aware of. Yeah.
Okay.
It also, it brings our society back a little bit in my eyes, because I think we were making some like really solid strides towards more acceptance of different body types, and GLP-1s kind of put the emphasis back on weight loss being like good.
A minute ago, you started talking about why it can be so dangerous to prescribe GLP-1s to someone with an eating disorder. I'm just curious what the medical complications of that could be.
Yeah, I think it would exacerbate any of the existing medical complications. So there are a lot of, I don't know if you talked to Becca about the medical complications of eating disorders, but it affects basically every organ system.
No, actually, we didn't talk about this much.
Yeah.
So I think it might be worth it.
Yeah. So yeah, eating disorders affect every major organ system. It's essentially like putting your body on a budget. Right? So when you go on a diet and you say, I'm only going to take in this amount of calories, your body has to decide where those calories are spent. And so it focuses on the most essential things, and some other things go to the wayside, right? So, for example, many women will stop getting their periods, right? That's one kind of telltale sign that you're not getting the nutrients that you need to function optimally. But also the brain is not getting the same amount of energy that it needs to be fueled optimally. We start to see folks become very cold. Their bones aren't getting the calcium that they need, so there's a greater risk for osteoporosis and osteopenia. And there's a certain window of time that girls and women can build up their bone density stores. I'm not a medical provider, but this is my understanding, and it's during kind of the adolescent period. And so if they do not receive the kind of nutrients that they need, they can't get that back.
Wow.
And so they're going to be at a higher risk for fractures and as life moves forward. But most of the medical complications from eating disorders, whether it's bradycardia, like slowed heart rate, or whether it is having, different vitals and lab work changes, right? Most of those can be remedied with proper nutrition and weight restoration.
Taking the medicine.
Yeah.
By taking the medicine, I meant
eating.
Food.
Yes, exactly.
Okay, so it sounds like essentially GLP-1s just exacerbate the risks that are already involved when you're not taking the medicine, aka eating enough.
Exactly. Yeah.
I'm just curious, to get a little more personal, like what do you like the most about working with this population?
I like working with this population because it's a challenge. It is very rewarding to see someone move from a state where they are very rigid in the way that they're thinking and behaving into like more freedom and expansiveness, and coming into getting to know themselves more. So yeah, I think it's very exciting to see someone come in a place where they're not doing well, and within a short period of time you can really see with nutrition and weight restoration someone kind of come back to life a little bit. But that's just the beginning of the journey. And I think people who get into this field care a lot about the folks that they're working with. I'm sure you feel that way too in your field. So I like the camaraderie of working with other people who are as passionate as I am about this. But yeah, it's a complex, difficult to treat disorder, and I find that challenge kind of fun.
Awesome. It is tricky. Like you said, it's a challenging disorder to work with. So what motivates you to keep doing it?
I think when you do see that, you see change and you see someone who has sometimes incremental change that is so exciting to see, and then sometimes you see someone a year later that you knew they were really kind of stuck in these cognitions and behaviors, right? And they're in just a totally different headspace and place in their life because they really engaged in treatment. So I think both on this sort of micro and macro levels, it's just very reinforcing when people are able to make changes. But even in the beginning stages, before someone makes stages, for someone to feel like someone can understand where they're coming from and there's hope for treatment and recovery, I think can make a really big difference. So even that level of providing psychoeducation and understanding and being non-judgmental around this illness, I think that's like a beautiful point of connection too.
Totally agree. All right, I'm going to give you a magic wand. With this magic wand, you can say whatever you want to anyone who might be struggling with an eating disorder. What might you say?
That there's hope, that this doesn't have to be how things are for the rest of their life, that they can get treatment, they can get well, they can flourish, and this can be in their rearview mirror.
Awesome. All right. Thank you so much for coming to talk to me.
Thank you.
Yeah.